Well, hello and welcome. On behalf of CME Outfitters, thank you for joining us today for today's CMEO briefcase titled Team Approach to Addressing Comorbidities in Aging Populations of People Living with HIV. So this program has been supported by an independent educational grant from Gilead Sciences. I'm Dr. Carlos Malvestuto. I'm an associate professor in the Division of Infectious Diseases in the Department of Medicine at The Ohio State University Wexner Medical Center in Columbus, Ohio. I'll be the moderator for today's briefcase.
I'm Dr. Milena Murray. I'm an associate professor at Midwestern University College of Pharmacy in Downers Grove, and also a system-level HIV ID clinical pharmacist at Northwestern Medicine in Chicago, Illinois.
The goal of today's educational activity is to empower learners to utilize team-based interdisciplinary care to optimize HIV and comorbidity outcomes in aging patients. Let's jump right into the case. Jeff is a 58-year-old male living with HIV for the past 30 years. He was diagnosed with hypertension 6 years ago and COPD 3 years ago. He used to smoke 1.5 packs of cigarettes per day for the past 20 years before stopping when he turned 48. He fell while getting out of the car yesterday and is now complaining of knee pain. He's on several medications. For HIV, he's on the single tablet combination of elbictegravir, cobicistat, tenofovir, FTC, and also he is taking aspirin 81 milligrams daily. He's on losartan 50 milligrams daily. He's on pantoprazole 40 milligrams daily. He's on tiotropium 18 micrograms per capsule, and he's on albuterol 90 micrograms inhaled. And he also takes over-the-counter pain relievers. So we can see that he's had an undetectable viral load of less than 40 copies per milliliter. He has a CD4 count of 580 cells per microliter. He had, for diabetes screening, his blood glucose is 90 milligrams per deciliter, and he has a hemoglobin A1C of 6%. His vitals show us that he has a BMI of 24. His blood pressure is pretty good at 118/78, and his oxygen saturation is 93% on room air. His lipids, he has a total cholesterol of 160, a low-density lipoprotein of 90, HDL of 52, and triglycerides of 130. We can see that his liver function tests show us an ALT of 38, an AST of 29, albumin of 3.5, and total bilirubin of 0.9. His kidney function, we see a BUN of 22, a creatinine of 0.9, and an estimated GFR of 99. Overall, just looking at this, what are your thoughts? What are some of the highlights?
Yeah, so I think that this is a typical patient that we're seeing in clinic where they are, aging. They have a lot of comorbidities going on. We're sort of worried about some things. They're borderline. Do we intervene now? Do we wait? When do we need to bring them back? I'll just point out too, we have a comprehensive medication list, which doesn't always happen in clinical practice. So I think it's actually great that we can see all of this and kind of assess things. Try to figure out why things were prescribed. Is each therapy optimized? Are we using guidelines to make sure we're guiding what we're giving? So I think there's just a lot that is in this case, and I know we're going to spend the next little bit of time talking about that.
Right. So already we can see that, just from looking at his medications and his labs, we can guess as to some things that could be issues. But there are also, for example, some medications not completely clear, why the patient may be taking them. Is the patient is on pantoprazole. This seems to be something that he's taking on a daily basis. Does he have GERD? And maybe, looking at that, he's also on aspirin. What's the reason for the aspirin? So, but I completely agree with you. This is a typical patient that we see in our clinics. Somebody that we end up having to ask questions and find out more about what may be going on. Now, we see that his biological age is 58. He has a number of comorbidities, and something that we've learned over the years about our people with HIV who are aging with HIV is that they tend to have more accelerated aging, or possibly they're dealing with more comorbidities at a younger age. So according to average results in frailty studies in people aging with HIV, what is the most likely biological predicted age? And the correct answer here is D, the age of 68. So we see that even though he's 58, this is actually 10 years older than his actual biological age. Is this common, for our patients? Is this, in your experience, what is it that you see in your practice?
I would say definitely about this range, and that comes into play when we're trying to treat comorbidities, when we're thinking about cancer screenings that we need to be aware of. So it definitely comes into play, and 10 years is about what we generally see. And
we see that in our population of patients living with HIV in the US, most of them are now over the age of 50. So as of 2021, more than 50% of all the people living with HIV, as we can see here in the graph, were over the age of 50. And it's projected that by 2030, over 70% will be over the age of 50. In this graph here, if we look at on the right, we can see that people living with HIV's lifespans, even though they now approach those of people without HIV, but there is that increased risk of premature aging and frailty. And as we mentioned, and in Jeff's case, more than 10 years of accelerated aging on average. But we also know that they also deal with more comorbidity. And this greatly impacts then the possible onset of frailty, which I think it's important that we at least have a sense of a definition for this. And what we mean by that is a state of vulnerability to negative clinical events. So patients with frailty are more likely to end up hospitalized, and they're more likely to progress to disability, to have falls, to have issues with polypharmacy. And it's important then to highlight that not everyone with HIV will age the same way. So there is heterogeneity in the population, as we well know. We mentioned that people with HIV are living with a number of comorbidities compared to those without HIV. For example, we know that people living with HIV have an increased risk of cardiovascular disease. In fact, now heart disease is one of the main causes of death among people with HIV. They also have earlier onset of issues of like osteoporosis. There's a higher prevalence of diabetes and metabolic syndrome. And as we also know that our patients then tend to deal with chronic kidney disease. Liver disease is an issue, and this for a number of different reasons, including non-alcoholic fatty liver disease. Lung disease is a problem. So we see that, for example, our patient here, he has COPD, he has a history of smoking, which also we know that there's a higher prevalence of smoking in our patient population as well. And then malignancy is also an important issue for our patients. Not only the AIDS-related cancers that we're used to, like non-Hodgkin's lymphoma, but also non-AIDS related malignancies. There are a number of studies that have shown that For example, even lung cancer in our patients is actually more common. Neurocognitive impairment is an issue as well. There's a broad range that goes from HIV-associated neurocognitive decline all the way to AIDS dementia, which fortunately become less common with as we've been putting people in effective antiretroviral treatments. And of course, the geriatric syndromes and frailty that we were discussing. And there are multiple mechanisms that will drive the premature aging and the onset of these comorbidities. In some cases, the HIV is an additional risk factor. So we know that, for example, for heart disease, it's an independent risk factor. And a lot of these are, we know that at least there's some contribution of chronic inflammation due to HIV, as well as immune activation. What other processes, do you see driving premature aging, and what do you think is important for the audience to pay attention to?
So I would definitely say two things in addition to the list, that we always want to think about mental health, because I think that can drive negative outcomes as well. And also social determinants of health, I would say almost thinking about those as their own comorbidity, because people who don't have access to transportation, stable housing, food insecurity, we're prescribing medications, some of which need to be taken with food, and we don't always think about that, and that we make assumptions that, someone is, stably housed and employed, that they have access to food, and that may not be the case. So we kind of need to, move beyond our definition of who we think about with that, especially when we're prescribing medications that some of which have a very high caloric content that need to be taken. So I think we also think about how these comorbidities interact with each other. So if someone has liver disease and kidney disease, when they have lung disease and now they're not able to exercise, that's going to impact other things like onset of diabetes. So I think that there's definitely individual comorbidities, and then the interactions between all of them, and then adding that social determinants of health kind of as a broader overlay, it definitely builds up to quite a complex continuum of care.
And, I know that we'll talk a little bit more about the impact of antiretrovirals, but, they can also contribute, to some of these issues as well. We're clearly now in an era of very effective and very safe antiretrovirals, but we still have to pay attention to some adverse effects of antiretrovirals. So we mentioned that metabolic syndrome, obesity is an issue for our patients, which may also contribute to then metabolic disease and negative outcomes. But we know that, for example, one of the most popular classes of ART, the integrase inhibitors, it does contribute to weight gain in our population. I'm curious as to, what are some of the guides that you follow, or, when it comes to actually trying to manage a lot of these issues. For example, when it comes to bone health, something that earlier on in my practice, I started to become aware of, and which is clearly recommended in the guidelines, is the onset of osteoporosis. And I used to think of it more as an issue for our older women, but then I started to see a lot of men in their early 50s who had osteoporosis, and which could be driven by certain medications, but we know that in HIV is definitely more common. So, for example, one of the recommendations is a DEXA scan to look for osteopenia and osteoporosis in all men 50 and older, and in all postmenopausal women. Is this something that you've seen? And then what medications can be contributing to issues with bone health?
So definitely, I think that once we started monitoring more, we were definitely uncovering a lot of very poor DEXA scores. And I think that just in general, overall, besides, medications like tenofovir, the tenofovir disoproxil to be specific, is causing, potential issues and trying to switch. But then even after switching, because there's so many other things that can contribute to bone health, like, for this patient, smoked for many, many years. So I think that, we want to be careful not to focus too much on medications, because we think, oh gosh, they're on a medication that quote unquote doesn't have bone effects. Well, there's probably 5 or 6 other things going on with them where there can be bone effects.
I think, that's an excellent point. And I think, sometimes there's almost too much of emphasis on the medications, and particularly in antiretrovirals. I think sometimes our colleagues in other specialties, they look at somebody who's an antiretrovirals and they think of, some of the adverse effects of the older antiretrovirals. Because we always get questions about, what the impact may be on the patient's health. And as you mentioned, for example, when it comes to bone health, yes, TDF can certainly contribute, but we also know that smoking is a big risk factor, right, for osteopenia and osteoporosis. Fortunately for this patient, he stopped smoking 10 years ago. But a lot of our patients who smoke, there are many reasons why that really should be a top priority in trying to ensure their a healthy aging for them. We can talk about cardiovascular health, and I think this is an important issue for our patients, and particularly when we have to assess what our patients' risk for cardiovascular diseases. The tools that we use are, for example, the ASCVD risk score, which we know underestimates the risk in people living with HIV. It does not take into account the impact of HIV as an independent risk factor. So it's important to keep that in mind. So somebody that who may have a low risk when we put in all the numbers into the calculator, but when it comes because of HIV, then the risk is could effectively be far higher than that. So in this particular patient's case, we know that the ASCVD risk score gives us a low moderate level, but it's very likely that the risk is quite a bit higher than that. So and the recommendations are changing quickly, and we'll talk about this in a little bit. But so we know that this patient is on aspirin. It's not clear why this may have been recommended to them. And interestingly, the evidence supporting the use of aspirin for primary prevention in people with HIV is not all that great. But there's now more recent data actually showing that a statin, for example, in people with low to moderate cardiovascular risk actually reduces that excess cardiovascular risk and mortality in people with HIV over the age of 40. So I think it's important to at least discuss and make an assessment about cardiovascular health in our patients. We also need to consider, when it comes to liver and kidney disease assessments, such as a chemistry panel with checking on hepatic function is important. And we may see some signs of some early signs, at least, of certain issues, like, for example, fatty liver disease, which we know is more prevalent in our patient population. You mentioned mental health before. What is it that we should be screening for, and how often should we be doing this?
So definitely, screening for depression and anxiety, especially with the new, recommendations from the preventative task force to screen for anxiety, at least once in adults. And so to say that we would do this at every visit, I think is hard. I mean, if we were screening for all these things at every visit, the visit would be 2 hours long. So I think that we have to both not assume, like if someone comes in and they, oh, this person doesn't seem like they have depression or anxiety, we don't want to assume that, we get a baseline screen and then maybe, do it every year or so, however we need, or if they have a life event or something like that. And so, that's the depression, mental health. There are screening tools for that. Substance use disorder is definitely its own conversation, making sure the person doesn't feel stigmatized, that they're able to talk about those types of things, because there can be other implications for disease states or potential drug interactions that we want to know about, and make sure that the patient feels comfortable letting us know everything that's going on so that we can work with them to make the best care decisions. And then neurocognitive impairment, I think this is something that's a little bit, again, harder to do every single time, but I think trying to do a yearly or a bi-yearly screen, just to make sure that we have a baseline and we can kind of see if there's any trends, which I think, that's important for many of these things that we're talking about, is really what are the trends in it, just to try to capture things as early as possible for intervention.
And we mentioned, from the beginning, how most of our patients over the age of 50 are on multiple medications, not just their antiretrovirals. So how much of an issue is polypharmacy, and what should we be doing about that? What should we be checking with our patients?
Yeah, so I'll give just a little bit of a teaser here, because I know I'm going to be going over this in depth in a few slides. So I think that anyone that comes in that is on more than 5 medications, definitely more than 10 medications, I think it deserves a closer look. I think this is much more prevalent than we think that it is. I think that we don't even have comprehensive medication lists. So when you start adding herbal supplements, over-the-counter meds, we can get up over 5 and 10 very easily. So it's definitely something that we need to be more cognizant of, checking drug interactions and making sure that we ask, because people certainly don't know to tell us. And especially once you ask them too, you might uncover someone who's taking way more of an NSAID than they should be for some reason, and maybe that's having an effect on their kidneys or their blood pressure. So it's definitely worth making sure we have that comprehensive list, because that will affect, honestly, everything else that's going on.
Absolutely. We also know that our patients tend to deal with more lung health issues. So, for example, this particular patient who has COPD. And that's something that we should be assessing for. And cancer screenings are particularly important, as we mentioned before. And then for our patients, we definitely want to make sure that they're keeping up with their colonoscopies. And at the same time, in our patient population, we see that anal cancer is more common. Recently, the results of the ANCHOR trial came out, which now tell us that for patients with precancerous lesions, high-grade lesions, then they should be referred to the colorectal surgery for actual treatment, as opposed to just monitoring. It's still not clear how frequently we should be doing anal cytologies. In my practice, for my patients, we do this annually. And if we find abnormalities, then we refer to colorectal surgery for high-resolution anoscopies and follow-ups. Similarly, we also need to consider that for patients with a history of smoking, that having a CT scan screening for possible lung cancer is important as well. And of course, making sure that our cisgender women are keeping up with, and transgender men who may need mammograms, that also they're keeping up with that. So there's a lot that we need to be paying attention to when it comes to cancer. The one last one is that diabetes, we know, is fairly common in our patient population. We've talked about certainly the fact that obesity is common in the U.S. population overall, but also in our patient population. Then there is an issue of possible weight gain that may be there may be some contribution of antiretrovirals as well. But doing a regular assessment is important. Even though the hemoglobin A1C may not be the most accurate measure in people with HIV, it's still a useful measure. It gives us an idea of where the trends may be going. But also we can use fasting blood glucose to then try and make an assessment and to at least identify pre-diabetes and diabetes in our patients. Anything else that we should be checking for? And as you said, this is something that particularly for our patients who tend to be very stable in when it comes to their HIV, we may be seeing them twice a year.
So definitely, with the vaccinations, with preventative health, I would say vaccinations are everybody's responsibility. So we know that there's data showing if, a specialist, so like, an HIV provider is going to say, oh, well, it's, the primary care doctor is going to do these. But then the primary care doctor may say, oh, well, it's vaccines, like the ID doctor should be doing this. So I think that then there's these people that fall through the cracks and they don't get vaccinated. So I think that everyone that sees the patient, if they have the availability in their clinic to give the vaccine, should do so. If they don't, they should be referred to, a pharmacy or someplace that does the vaccinations. I know we use, immediate cares as well, and that should be followed up on too. So I think overall, we want to make sure that we're screening, that we're also very up to date. The vaccination schedule does change fairly regularly, I would say, for people with HIV, especially those who are aging. We have newer vaccines that come out, better vaccines for this population. So it's definitely something to keep up with. But really to make sure we're all taking responsibility for that and not just assuming that another provider is going to look at that vaccine schedule and make sure the patient is up to date.
Yes, I completely agree with you. And I think also sometimes, the primary care provider may be used to their patients who are not immune compromised, who may be on a different dosing schedule when it comes to vaccines. Like, for example, we know that for our patients, we want to give them the pneumococcal vaccine, really from very early on, not without waiting until they're older than 50, for example, or same thing with the shingles vaccine. That is something that can be a big problem for our patients. So given that earlier, and we know that, that is actually something that is recommended now for patients over the age of 18 who are living with HIV. We mentioned the issue of cardiovascular disease in our patient population, which is very common. And our patients in general, we can say that the risk of cardiovascular disease for somebody living with HIV can be just about double that of somebody without HIV. So that's why it's very important that we look at all the risk factors that can be contributing. So HIV is an independent risk factor. And so obviously the best thing that we can do about that is to make sure that the HIV is well controlled. But even when HIV is perfectly controlled and the patient is virally suppressed, there is still this ongoing chronic inflammation and immune activation that then contributes to the earlier onset of heart disease in our patients. So we see a higher incidence of myocardial infarction, a higher incidence of strokes in this patient population. So when it comes to making an assessment, and this is an area that's now changing, the recommendation has been to take into account any HIV-related cardiovascular risk enhancing factors. So we can use the ASCVD risk calculator to get a sense of what the score may be, of what the patient's risk may be. And then, if somebody has had, for example, a history of prolonged HIV viremia before they started or delayed ART initiation for a long time, or if they had a low CD4 nadir that was below 350 cells per cubic millimeter, or they have a history of non-adherence with their antiretrovirals. These are all cardiovascular disease risk-enhancing factors that have to be taken into account, and then trying to decide what should be done to prevent the onset of heart disease in these patients. And now we have the results of the REPRIEVE trial, which recently ended. This was a very large trial of over 7,000 participants who were enrolled in 12 countries around the world, and they were followed for a median of over 5 years. And this study was stopped early after the Data Safety Monitoring Board determined that that efficacy and had been achieved, and the study met its primary endpoint. So participants had been randomized to receive either a statin called pitavastatin daily, or a placebo. This was a double-blind, randomized controlled trial, and all the participants had to be virally suppressed over the age of 40, and they could not have cardiovascular disease, at baseline. What we know is that the patient population had a median ASCVD risk score of just about 5%, which is considered then a low ASCVD risk score. But what was shown was that there was a 30% reduction in the incidence of cardiovascular disease and mortality in this population. So the results are just going to be coming out very soon, but we know that this is likely going to lead to a change in our practice, because now we should be considering that for all our patients over the age of 40 with who are living with HIV, then we should be considering actually starting a statin. And in this study, the statin was specifically pitavastatin because of the fact that it does not interact in a significant way with protease inhibitors and NRTIs, so it does not require dose adjustment for any of the ART regimens that we use. And also because it had shown that some good impact on immune activation and inflammatory markers in people living with HIV. But the truth is that it's very likely that other statins probably have the same pleiotropic effect and the same protective effect. Again, it highlights, this something that we've wanted to achieve, which is reducing that excess cardiovascular risk in our patient population. Adding a statin may be one way to do this. Again, without forgetting about all the other important risk factors. Making sure that if a patient is smoking, really working with them to achieve smoking cessation, controlling blood pressure, and all the other risk factors, all the other traditional risk factors. Let's talk a little more about the considerations related to antiretrovirals in people living with HIV. So now, we have all these different classes and all these different medications. What are some important points that providers should keep in mind about antiretrovirals in people aging with HIV?
So we have a few different populations that we need to think about. So we have people who are naive to treatment, who have, maybe just be diagnosed or haven't been on treatment. Now they're coming on the treatment. We have the population who are switching. So, we're in this age of beyond undetectable. And so we need to be thinking about, just because someone is undetectable doesn't mean that they don't need a change in their ART. And so that's our switch population. And then, of course, we have our highly treatment experienced population where, depending on other comorbidities, we may need to be, focusing more on which drug do we need to treat the HIV. And that could impact based on drug-drug interactions or other pharmacodynamic interactions with other comorbidities. So on this slide, we have all the classes of ART, and then we have some class notes, and then more specifically for age notes. So for the INSTIs, we know that these are our, very well tolerated. They are recommended in the guidelines for populations that we're not as concerned for drug interactions with these. Although as a pharmacist, I will say there's never a time when there's like no drug interaction. So there still are drug interactions with INSTIs, but they are fewer, much fewer than we're used to. But I will caution our audience to always check for drug interactions because they still do exist with the INSTIs. We need to make sure we're thinking about, drug interactions specific to our absorption, because if they're given not timed correctly with food and with calcium, aluminum, et cetera, there can be an issue. We need to think about people who are aging, do have GERD, have more of these GI issues, that they may be using those over the counter more frequently. For our NRTIs, not too many side effects, especially when we think about our newer agents that we're using. We have mentioned before, the differences between the tenofovir disoproxil fumarate and then tenofovir alafenamide when we're thinking about renal and bone disease. I think a lot of the issues with weight gain are coming to fruition, but we're still not really sure exactly what all of the confounders for that are. But it's definitely something to keep in mind, especially dependent upon the goals of the patient regarding their weight, if they're already overweight or obese, and honestly treating them for that too, and not using an antiretroviral as a weight suppressive agent, or because we want to make sure that they're able to get their weight to where they want their goal to be. And then of course, abacavir and the potential for cardiovascular risk. So again, as you mentioned, many times we're talking about cardiovascular risk factors. So we don't want to be adding to those risk factors if it's not necessary. And I think that we have other agents that we can use that we don't need to take that risk. For our NNRTIs, again, really thinking about drug interactions, efavirenz, obviously many CNS effects, rilpivirine, the same, our older ones, that aren't really used as often anymore. Newer doravirine. We talked about food insecurity, so that does not need to be taken with food, which is important, and fewer drug interactions, fewer potential effects on weight and things of that nature. For our PIs, again, we know those are the classic drug interaction issues, so we need to be monitoring for that. However, there are people for which they do need a protease inhibitor if they have resistance, if they have issues with adherence, et cetera. So there are places for protease inhibitors, but in the aging population, if we don't need to use them based on drug interactions, issues with metabolic syndrome, et cetera, and again, making sure that we're really going beyond undetectable and seeing what they might need. But there's definitely a time and a place for the protease inhibitors. And then the entry and capsid inhibitors, we're thinking more so of our highly treatment experienced people, though, fostemsavir, is indicated in people who need that drug because of other side effect issues and not necessarily just for resistance. So thinking about that as well. And so, these drugs, some of them are injected, some of them are an infusion, so that can cause issues, with a person getting to clinic for that, having to come back more frequently than they're able to. But definitely, thinking that we do have options, many more options than we did for that highly treatment experienced population. So overall, again, with all these considerations, not just looking at the viral load, but thinking about how is this drug affecting the other comorbidities? How is it interacting with other medications? For example, if someone were to be diagnosed with cancer and the chemotherapy was going to interact, at that point, yes, we need to switch the medication, because at that point, the cancer is the more prominent issue, and we need to make sure that these drugs aren't interacting. So I think people will change antiretroviral therapy more times in their lifetime than we think that they might, based on drug interactions, comorbidities, new drugs coming out. So when we're thinking about these drugs, I don't think we can really think about, this is a lifelong therapy. Obviously, the person will be on lifelong therapy for HIV, but it probably won't be what they're on today. So it's just a different way of thinking about that and trying to be a little bit more dynamic with that, based on whatever else is happening with the patient.
And that's a very interesting point, because I think in the early days, the message that our patients would receive, and particularly our long-term survivors, our older patients, was once you are on a regimen that works for you, you stay with that until, because the thought was that eventually that would fail and there would be a need to change. So we were trying to really spare any changes, and actually only just use what we something for as long as we could. But that has changed now that there are multiple options, and something that may be a great option for one patient may not be the best for another patient. So completely agree with you. I find myself sometimes trying to convincing my patients why a change may be necessary. And sometimes they're a little hesitant because they feel that, well, this has been working. My viral load has been undetectable now for years on this. Why do I need to change? So, sometimes we need to discuss, why something else may be a better option for them as they're getting older. And on that note, what should we tell Jeff? So which of the following ART strategies is the best choice for Jeff based on the antiretroviral guidelines and his personal characteristics and history that we've been discussing?
So the correct answer is D, switching to bictegravir, emtricitabine, entecavir, alafenamide. We know that this is the least likely to cause drug interactions of the options listed there. Non-boosted PI regimens are really not recommended, even as an alternative now. And then again, given his potential for cardiovascular disease risk, his lipid profile, if we do not need a protease inhibitor at this time, we were given no information about any resistance or whatnot, but we're assuming that he's not resistant and that he does not need a protease inhibitor. Then for sure, the bictegravir having fewer side effects, having less drug interactions, and then the tenofovir, alafenamide potentially having less effects on his kidneys as well as bones, especially given his what appears to be decreasing renal function at this time. So now that we've decided to make a change in Jeff's medications, we really want to make sure we're thinking about all of his medications at the same time. So how are they all going to interact with each other? So we want to think about polypharmacy. And while there's no universal definition for this, typically anyone who's over 5 medications, we would consider polypharmacy an issue. And as I stated before, that's very easy to do, especially in our aging population, especially if 1 or 2 of those are already taken up with antiretrovirals. And so we know in this population, there's a high prevalence of polypharmacy. They may be taking inappropriate drugs based on drug interactions, et cetera. And one thing that we need to be very cognizant of is pill burden and pill fatigue, especially in our population that's aging, that has maybe been on medications for 30 years. And at the beginning, they had to take, more than 5 tablets a day. And even though now they're down to 1 tablet a day, just that reminder of their diagnosis every day can have an effect. The tablets are becoming smaller. We are getting more different formulations of tablets. However, this is definitely something that I talk about with people when I'm switching their medications and showing them, an example tablet, if possible, to say, is this okay? Will you be able to swallow this? Also, in our aging population, people may have other issues. They may have had types of surgery or other things making it difficult for them to swallow. So it's just always something to think about, the number and type of medications. In terms of our outcomes, we know that drug interactions can be devastating in terms of threat to resistance if someone's taking medications inappropriately, and then they become resistant to an entire class of antiretrovirals. That can be honestly catastrophic in a way. These drug interactions in the aging population can lead to falls. So we saw that in our patient today, fell getting out of his car, and that could have been due to something like a drug interaction, and maybe not just accidentally caught his foot somewhere or something of that. And then we get into this idea of prescribing inertia and a prescribing cascade, where we give one medication and then, potentially we give an antiretroviral, and that may cause nausea. And then now we're treating that person for nausea. And then that, anti-nausea medication is going to have, anticholinergic effects. And so then we're treating that, and on and on and on it goes until now this person's on 5 or 6 medications. One is to treat HIV, but then the rest of them we're trying to treat the side effects. So really trying to think about the origin of the side effect, what could be causing it, how we're recommending to treat those side effects. Now, in some cases, we may not be able to get around it, but we just really need to be cognizant of that so that we don't add on medications that aren't necessary. And one other really important tool that we can use is to deprescribe. So to look critically at each medication. As you noted, we don't know why this person's on aspirin. Is that something that maybe we can deprescribe? I can't tell you the number of times I've had people come to me on everything from lorazepam to warfarin, and they have no idea why they're taking it. Someone just keeps prescribing it. And so trying to be a detective and track that down to deprescribe those medications, I think is really important. And that can be a conversation with the patient as well. Like, why are you on this? Can we stop this? Let's stop this, see how you're doing, especially if we think that medication is having negative effects on another comorbidity, that they're having a side effect from it, to try to really tailor the regimen down to the least number of medications they need. So I'll ask you, how do you incorporate deprescribing into your practice?
Yeah, I think this is this fantastic advice, and I find myself dealing with these exact issues very frequently with my older patients. Sometimes they're not really sure why they're on something, and sometimes a medication gets refilled that was initially prescribed acutely for a certain period of time, but for some reason ended up on the medication list. It was never taken off, and it just continues, and it's maybe refilled by somebody else. So going through and then doing a medication reconciliation for every visit, and making sure that it's clear both to the patient and to me why the patient is on something is very important. So I try to follow your advice and deprescribe, whenever possible. And I question, does the patient, or if they've been on something like, for example, a PPI, right, which are the types of medications that are very commonly prescribed, maybe for an acute episode, and then a patient just ends up taking it and it becomes something that they take chronically that they may not need anymore. Or when it comes to pain medications, anti-inflammatories, NSAIDs. I really like the way that you went over these principles and how important it is and how much of an impact it can have on our patients.
So our last audience response question is, which combination of Jeff's medications is most likely to have contributed to his fall? So the correct answer is A, the losartan and the OTC sleep aid. We know that there can be an interaction there where, losartan could be causing some lower blood pressure. With his vital signs, we see that he is very well controlled on this one medication. So it is possible that if his blood pressure dropped lower, that could have contributed. And then along with, the OTC sleep aid, which is further, depressing his nervous system. So those two things together could have contributed to his fall.
I think we discussed a lot of important points. Now, just going over the case, we talked about how he was diagnosed with hypertension, and because of that, he was on losartan. But given that he was taking a sleep aid, that could have very well contributed to his fall, which is now leading to his complaint of knee pain. We talked about the fact that this patient may very well need to be, or at the very least, there should be a discussion about starting a statin, and in that case, then taking into account the possible interactions between some statins like atorvastatin or rosuvastatin with other medications. We talked about how we would want to recommend a change in his antiretroviral regimen, and we to reduce possible impact on kidney function, on bone health, and also to reduce interactions with other medications. We talked about the other medications that the patient may be taking over the counter and their impact on his health, including his use of a sleep aid and pain relievers like NSAIDs, which can then certainly contribute to some of his comorbidities. So, a great example of the type of patient that we see on a daily basis, and the considerations that providers should be making when they're seeing their patients who are aging, to make sure that they remain healthy as and that they thrive in their as they get older. What are some of the things that you and your team will do to ensure that we're all on the same page when it comes to taking care of our patients?
Mm-hmm. So, I'm very lucky. The clinics I've worked in, we've had, obviously the providers, but nurses, social work, pharmacists, all trying to work together. And so I think the big thing is really just, follow up. So for example, when maybe the provider finds out that there's an issue with medication access, and, is it an insurance issue? Is it a copay issue? And so having the pharmacists and the social workers work together on that, but then, following up to make sure, okay, was that medication picked up? So I think for me, the biggest thing with multidisciplinary care is the follow-up. So if we're, wanting to refer to neurology for assessment, following up, did the patient go? Did they make an appointment? Can we help them make an appointment before they leave our clinic today? And then if we find out, gosh, the first available isn't for 6 months, is there something we can do, or is that appropriate? So I think just trying to be, a place where the patient can have everything done before they leave. And, whether it's a patient care liaison or like a social worker sitting down with them, navigating insurance, just because, the other provider is affiliated with the institution doesn't necessarily mean maybe they take all the insurances. I know there can be very different, financial issues that go along with that, making sure the person understands what their payment might be if, say, a neurological assessment is covered under medical. And then what does their deductible look like what time of the year is it, so I think that there's a lot going on there. A lot revolves around finances, but really just the follow-up at the end of it. I think, if we're referring to cardiologists, did they go? If the hepatologists, did they go? And kind of realizing that, this is a large burden on the patient as well. Like, they have to go, do they have to park? I'm in downtown Chicago, parking is very expensive. They might have to take time off of work, et cetera. So just kind of really being cognizant of, do they need the referral? Because if they don't, they might not be able to go. Can we do multiple appointments in one day? Can they come downtown and see multiple people? Can we coordinate that or not? So I think that, as we've said, there's definitely, we need this team-based approach, but we have to make sure that there's good communication among the team members as well.
Well, thank you, Dr. Murray, for your insights today. I think we've all learned something. Let's pull it all together with our SMART goals to apply in practice. So after today, we hope that participants will include an assessment of frailty and accelerated aging in age-related risk assessments for every patient aging with HIV. They'll use clinical guideline recommendations and best available evidence to implement best practices in the monitoring and management of chronic comorbidities for patients aging with HIV. To think beyond undetectable by reviewing both HIV-related and unrelated medications for polypharmacy concerns, ART optimization strategies at every visit, and to coordinate with a multidisciplinary care team to maximize whole health outcomes for people aging with HIV. So be sure to check out the other activities in this CMEO briefcase series. HIV and substance use disorder, addressing barriers to viral suppression, switching ART due to treatment resistance, ART for people living with HIV who are pregnant or of childbearing potential. Thank you all for participating and providing the best care for your patients. Take care.